Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Frank Jackson. He's a maternal-fetal medicine fellow. Today's Kevin MD article is Affordable Postpartum Hemorrhage Solutions Every OBGYN Should Know. Frank, welcome to the show.
Hi, Kevin. Thank you for having me.
All right, let's start by briefly sharing your story and then jump into the Kevin MD article and tell us what it's about.
All right, so I'm a maternal fetal medicine fellow. I trained originally in Connecticut during the pandemic when we were going through a lot of supply shortages and figuring out how to take care of patients on, less than we used to have traditionally. And then I moved on to fellowship here on Long Island and, got very passionate about the topic of care of our postpartum hemorrhage patients.
All right, so tell us what your article is about for those who didn't get a chance to read it yet.
Sure. So it's about a technique for vacuum-induced uterine tamponade or for postpartum hemorrhage. So essentially, back in 2020, the new way of treating postpartum hemorrhage came out. We started using this device called the Jada, which is essentially a suction tube that goes inside the uterus and helps control hemorrhage very, very quickly. And it was completely transformative for us as OBGYNs in the United States. Many labor and delivery units transitioned to using this. However, as supply shortages were hitting all of us across the United States, part of my mindset came to how would I live? What would I do to take care of my patients if I didn't have this device?
Mhm.
Looking around our labor and delivery unit, thinking about what people had done in the past, thinking about what would be available in any situation, my thought was, well, the Foley catheter is something that we are all familiar with as OBGYNs. It's something that we've seen used time and time again for hemorrhage or in labor. And so if I could hook that up to suction, that would potentially do the trick. And a case came by probably about a year ago where a patient had a hemorrhage and they weren't eligible for the Jada. Their cervix was not dilated enough for the Jada to fit. And so I tried out the technique and it worked like the Jada would have worked. So I published that case report and I started thinking, this worked very well for my patient. However, there are many patients who die of postpartum hemorrhage worldwide. So approximately 70 to 90,000 women a year die of postpartum hemorrhage. And it's not generally because we don't have the know-how. It's not because the technology doesn't exist to save their lives. It's because the technology is not available to save their lives in every setting. And using a Foley, which is available in pretty much every labor and delivery, every ED, worldwide, was something that could actually transform that. And so I started thinking, how do I spread the word for OBGYNs to know that these techniques are available? I came across STUT, which is similar to Focus, where we use a gastric tube instead of a Foley to do uterine tamponade, and thought, well, both of these things could be inserted in the uterus, hooked up to low wall suction when a patient is hemorrhaging, and could control the hemorrhage very quickly. There's some good studies that show that STUT works very well. There's a few studies that we're working on that show that Focus work very well. And I figured, I'd write to Kevin MD and make sure that your readership knew that this is an option if they don't have anything else available to provide this care.
All right. So before talking about some of these techniques, just give us a little bit of context in terms of how common postpartum hemorrhage is. You did mention some data in terms of how many women died from it. What are some of the risk factors? How much should it worry OBGYNs in the delivery room?
Sure. I mean, every OBGYN is very familiar with postpartum hemorrhage. So in the United States, about 3 to 5% of patients receive blood transfusions after their delivery. There's a multitude of risk factors for postpartum hemorrhage. So patients who it's their first baby are at risk for postpartum hemorrhage. Patients who have cesarean deliveries are at risk for postpartum hemorrhage. Patients who've had many pregnancies in the past are at risk for postpartum hemorrhage. So people who've had more than 5 deliveries. People with clotting disorders at high risk. Higher BMI puts patients at higher risk. And then there's some conditions that put patients at exceedingly high risk. So
Hmm.
certain conditions, for example, like having a placenta accreta, where the placenta is morbidly adherent to the uterus, puts patients at very, very high risk for postpartum hemorrhage. Preeclampsia, which is a common condition of high blood pressures in pregnancy, increases the risk of postpartum hemorrhage as well. In terms of how we manage postpartum hemorrhage, as OBGYNs will know, and is a new development since some of us have gone to medical school, now we've taken steps prophylactically
Hmm.
to prevent postpartum hemorrhage. So it's routine in the United States now for every patient to receive oxytocin to prevent postpartum hemorrhage, but that doesn't work all the time.
Hmm.
So when that doesn't work, sometimes we have to turn to devices like the Jada that I spoke about,
Hmm.
or we have a different device called the Bakri that also works by putting pressure outwards instead of pulling it inwards. And then in some cases, people lose their fertility. They have to have hysterectomies in order to stop the hemorrhage.
So tell us a little bit more about the JADA system. It sounds like that's standard of care. How often is that used, or how recent is that development?
Sure. So the Jada was first described in 2016 in a small study of 16 patients in Indonesia. And essentially, the way that the JADA system works is instead of applying pressure outwards, like some of the prior techniques have been doing with uterine balloon tamponade, we're sucking the walls of the uterus in, which is much more physiologic.
Hmm.
And so that was followed up with a larger study, the Pearl trial, which came out in 2019 or 2020, which in 100 patients showed that the JADA was very effective at controlling hemorrhage. So within 5 minutes, the majority of hemorrhages were controlled. Over 90% of patients who were having significant hemorrhage stopped having a significant hemorrhage. And so at that point, the device became marketed across the United States to different labor and delivery units. And for many of us, it became transformative. Just from clinical experience, we could see that patients were doing better, faster with the JADA than they were with the Bakri. So when I started as a medical student, when I started as an intern, we didn't have the JADA, and we would place the Bakri. And the Bakri is a good device, but we saw that when the JADA came along, our success rate of controlling hemorrhage was appeared to be significantly better.
Hmm.
And so, at least in the units that I've worked in, we've switched predominantly to the JADA for postpartum hemorrhage control, just because it seems to work better in our experience. There's a couple studies that have looked at efficacy of these two approaches, the balloon where we push outwards versus the JADA where you draw inwards. Some have shown that the JADA works better, some have shown equivocal results. But I think in the United States, I would suspect that it's about 50% of OBGYNs are using JADA as their first device nowadays, which is pretty astounding for something that came out just 5 years ago.
So before Jada,
Mhm.
were obstetricians using things like the Foley catheter or the suction tube?
So sure. So before the JADA came out, what people were using for the most part was something called the Bakri balloon, which is
Hmm.
essentially it's a large Foley catheter that goes inside the uterus that blows up to push out the uterus. And then the alternative in lower resourced areas is people would do what's called a condom catheter,
Hmm.
where they would take a Foley catheter, they would wrap a condom over it, tie up the bottom, and then they would backfill it to essentially create a large balloon. And so essentially what they would do is create a balloon that was about the 500 cc's of fluid, and they would push the uterus outwards. Now, when you're trying to control hemorrhage in obstetrics, what you're trying to do is actually shrink the uterus.
Hmm.
So all the medications we give, the urotonics, so oxytocin, misoprostol, methergin, hemabate, they're all meant to shrink the uterus down.
Okay.
When we do surgical interventions before we move on to a hysterectomy, when we do a B-Lange suture, that's to contract the uterus or help bring it down. And so the only intervention that we're doing that makes the uterus bigger is this uterine balloon tamponade. And so that's what we were generally doing as devices up until the JADA came out. And the JADA is really what switched us to thinking about suction. And so when the JADA study came out, that's when people started investigating these other devices. So
Hmm.
the gastric tube, there's a group out of South Africa, Dr. Hoffmeyer, that published on this. They just published the first randomized controlled trial, actually looking at vacuum-induced tamponade versus uterine balloon tamponade, and they showed that it is very promising to do vacuum-induced tamponade over balloon tamponade.
Hmm.
And that is the first study that actually compares the two head-to-head. They found that they achieved the desirable outcome of hemorrhage control much faster with vacuum tamponade. They found that we had lower blood loss with vacuum tamponade, less blood transfusions with vacuum tamponade. And the results are so promising that the WHO is pursuing a large randomized controlled trial right now called the RED trial to establish once and for all whether vacuum tamponade should really be the one first line standard of
Hmm.
care before we go to balloon tamponade. But it's really a recent development for the past 5 years.
So now that we're in a post-pandemic era and presumably we don't have a shortage of resources, where do you see the role of the Foley catheter or the suction tube techniques?
So, when we think about focus, which is a Foley catheter hooked up to suction, or STUT, which is a gastric tube hooked up to suction, we're really talking about one in high resource settings when patients aren't dilated enough and they have a contraindication to
Hmm.
the JADA. And then when we're in low resource settings, there's plenty of settings where we can't access the JADA. So information on the cost of the JADA is individualized to the hospital. It's not necessarily publicly available. There is one article that quotes the cost at about $1,000, which for high resource settings like Long Island, New York, or Nashua, New Hampshire, the JADA is available and affordable to save
Hmm.
women's lives. But in many settings, they don't have $1,000 for a
Yeah.
device that sits on the shelf and might expire. So I've actually heard from many midwives who deliver in the United States and do home births where right now they don't have a good device to do vacuum-induced tamponade, or from OBGYNs in Africa, but even OBGYNs in countries like France or Switzerland where they don't have the JADA because it's cost prohibitive. And so even in what we would consider high resource areas, there is a need for an affordable option to help manage hemorrhage.
So, talking about the rest of the world, you said the kind of lower resource settings. Is Focus and Stud, the Foley catheter G tube, is that standard of care there?
So they're not standard of care yet. So what's happening in the United States, vacuum-induced tamponade has become standard of care. That is not the case in other countries. I've spoken to OBGYNs, for example, in France, who say when they come to the United States, everybody talks about the Jada like
Yeah.
it's God's gift to obstetrics, but it's too expensive for France. And so in France, they don't use it. They still do uterine balloon tamponade. I think what's going to happen in the next couple years is when that WHO RED trial comes out, I think they'll confirm the study results that Dr. Hoffmeyer had in his initial STUT trial and show that vacuum-induced tamponade is actually superior to uterine balloon tamponade. Once that happens, I think that it will become standard of care for anywhere that has suction that's readily available.
And what do you see going forward in the United States? Do you still see Jada type systems or Jada kind of still becoming standard of care? Or do you still see these lower cost techniques still being used in kind of rural areas or lower resource settings?
I think what's going to happen in the US is, at least in the short, medium term, and at least in my practice, what's happening is that when a patient is appropriate for the JADA, people are going to use the JADA, and I think it's going to happen more and more. So ACOG, the American College of OBGYN, just came out about a month ago or so after the article I wrote actually was published, that now having vacuum-induced tamponade devices should be standard on every labor and delivery unit. So you should
Mhm.
have now there's a recommendation we should have both types of devices available, which was not the case up until very recently. So I think every labor and delivery unit is going to start having these supplies, and I think when a patient's a candidate, we're going to go to JADA because it's the unlabeled device. That's the device that has the most efficacy and safety data around it, and that's what we're going to reach for first. But there's plenty of cases where patients can't have JADA and where we will still need to reach for the Foley balloon. So, for example, there's cases where people have second trimester pregnancy losses or even first trimester pregnancy losses where we've used Focus. There's patients who have cesarean deliveries where they're not dilated yet. The JADA can't go into a
Hmm.
patient unless they're at least 3 centimeters dilated. Right now, those patients have no option for vacuum-induced tamponade unless they reach for a Foley or a gastric tube. And I think in well-resourced American hospitals, that's where Focus and STUT fill a gap, is these places where you're looking at the list of contraindication to JADA. You say, well, JADA is contraindicated in this situation. Let me reach out for a Foley and use it the exact same way as I would use the JADA, put it in the uterus, hook it up to suction, and it works the exact same way.
And how about in academic medical centers, like you're a maternal medicine fellow? Are these fellows and residents, are they being trained in all of these techniques?
Yeah, so residents and fellows are starting to be trained in these techniques. And then the other development is the A1, which is the overseeing body of OBGYN and neonatal nurses, has expressed interest in Focus because they're on the field, they're on the ground talking to nurses in all over the country, and they're training nurses in postpartum hemorrhage management all over the country, and they see the value in having a device that's low cost and that can be used on in any labor and delivery or even ED setting nationwide, especially for these patients where we know, for example, C-sections are a risk factor for hemorrhage,
Hmm.
but we can't put the JADA in every C-section patient.
We're talking to Frank Jackson. He's a maternal-fetal medicine fellow. Today's Kevin MD article is Affordable Postpartum Hemorrhage Solutions Every OBGYN Should Know. Frank, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Sure. I mean, I think the first thing is when you have a woman who's got postpartum hemorrhage, stop and think. You want to, be calm and composed. And once you've, taken that time, use the same principles you would use to save the patient, even if the tool that's available to you is not, right? So if the JADA is not going to work for you, think about the other tools that can fill that gap. I think that Focus and STUT are two tools that make it a lot easier to manage postpartum hemorrhages in these situations where we couldn't have used the JADA in the past. And the other piece I think is if you're a physician who has some idea on how to help people out, don't keep it for yourself and make sure that it's something that's available for all.
Frank, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you, Kevin.